Meniscus testing. A new study questions current thinking. This presentation will use a recent study on the accuracy and value of a commonly used test for meniscus tears to review clinical testing for meniscus tears as a whole, and also discuss why it's difficult sometimes to find the relevance and apply the results from the literature in diagnostic testing in practice. Well, first, context. There is a 45% lifetime chance of developing knee pain, and 50% of patients consult a medical specialist or PT within 1 year after the onset of symptoms. We don't have the statistics for chiropractors, and certainly this would vary based on the type of practice. Specifically for meniscus injuries, meniscal tears in athletes account for about 15% of all sports injuries. Approximately 25% of knee surgeries are for meniscus tears. Given how common and important a problem knee pain and meniscus injuries are, it would seem that by now clinical testing would have been developed that would be reliable and valid. In fact, many clinicians believe that the tests they were taught are, and don't realize that the tests they learned often have not been validated as either reliable or accurate, and therefore they trust in them implicitly. So clinicians are confused by why it is so difficult to find a test that detects a damaged tissue such as a meniscus tear. The assumption is that if you irritate or challenge the structure, it should cause pain, so a provocative test should be relatively easy to find, and that challenge can be isolated to that desired structure. What isn't evident on face value is the complexity generated by multiple variables. Well, let's discuss those variables. Many structures are pain sensitive, so many tests cause pain without being specific to a specific structure in the knee. Even the meniscus is not entirely reliable as a pain source. Past studies have indicated that only the portion attached to bone is relatively pain sensitive. In any case, if bone is damaged or the ACL, PCL, capsule, or associated ligaments are torn, pain will occur, so pain itself is not an isolator. Even joint line pain can be caused by capsular or coronary ligament tears. Consider these variables: the age of the patient, whether a child, adult, or senior, the gender of the patient. Is the injury acute, where swelling changes the patient's reaction to testing, or even the ability to perform the test, versus a chronic tear, where swelling has mainly dissipated? Is it a medial or lateral meniscus tear? Is it a traumatic or degenerative tear? And what type of tear? Peripheral or deep, radial, horizontal, unstable or stable? Then there is the performance of the test and the interpretation of the test. In addition to different descriptions of the same test in different texts, everyone has their own variation of how to perform tests, so results often vary. Positive findings also vary. In other words, for a McMurray's test, some might require clicking or clunking, while others only require pain provocation. Testing may be intended to find a single pathology, but when multiple pathologies, such as a terrible triad, occur, meniscus, ACL, and MCL, how does this affect how well a test performs? Finally, the mechanism of challenge is often similar across tests, but the variation is how to apply that challenge, so that there are perhaps 20 tests for the meniscus, most attempting to add a combination of compression and rotation, simulating the most common mechanism of injury. These are all theoretical constructs, so it's difficult to know which are actually doing what the designer of the test assumed they were doing. When looked across broadly, the evidence for meniscus tear detection is not consistent. Why? Because all these variables just mentioned are found in studies that test performance. In other words, studies either focus on a subgroup or category of patient type or meniscus type, and so therefore results can't necessarily be applied to the other types. For example, if the study was a sports practice with younger patients and a traumatic onset, that may not compare to an older patient with a degenerative tear in general practice or match the patient in front of you. Oh, and then we have the gold standard used in the studies. It's clear that arthroscopy is probably the best standard, given it is direct visualization, yet many studies use MRI, whose accuracy is not perfect. So let's review some of the different indicators for meniscus tears prior to looking at a recent study. Let's look at history indicators for meniscus tears. We see here that 92% have pain, 95% have discomfort, 56% have swelling, 47% clicking, and 12% locking. The problem, of course, is that these symptoms are not exclusive to meniscus tears, and that meniscus tears are often found associated with other pathologies. Tests then might be very sensitive, but not very specific to a specific structure. Now, let's look at the exam. We know that the general principle of most meniscus testing is to compress and rotate in an effort to provoke pain. As a result, they are all variations on that theme. Some use an axial compression force with gravity, such as the Thessaly Test and others. Another uses examiner-imposed axial compression with the Apley's compression test. Others are compression that results from full knee flexion, such as duck walking or the first part of McMurray's. And others use the movement of the meniscus on internal and external rotation to attempt to add more compression. Using the Thessaly position as an example, there are at least 2 other structures challenged based on other studies. This includes the ITB and the fibular head. Then we have the variation of possible positives, which can include pain anywhere in the knee, pain at the joint line, or clicking, popping, or a thud. Regardless of the test tested, there are some standard terms we need to review prior to reviewing the results. The first is sensitivity, and our acronym is SNOUT. A highly sensitive test, when negative, helps to rule out the disorder. The next is specificity, and the acronym is SPIN. A highly specific test, when positive, helps to rule in the condition. Without going into the specifics, these 2 statistics help in determining the value of a test in either detecting or ruling out a disorder. So let's look at some of the values already in the literature. Here are some ratings for 3 tests or findings. Why such a range? For all the reasons we mentioned earlier. Dependent on the focused population, the criteria for a positive test result, and the gold standard used, these variations occur. Even special imaging is not perfect. Here are the stats for MRI. You can see it varies based on which meniscus is evaluated. Notice a new term here, accuracy. It is a summative value, meaning accuracy is the proportion of patients accurately identified. In other words, all of the correctly identified patients with meniscus tears plus all the correctly identified patients without, taken together as a proportion of all the patients. Now to our study of interest. Some tests only have a few or even a single good study that evaluates their value. For the meniscus, that test is the Thessaly Test. It is regarded, based on a few studies, to be of high value, but a recent study questions that assumption. The title is Validity of the Thessaly Test in Evaluating Meniscal Tears Compared with Arthroscopy, a Diagnostic Accuracy Study, published in the Journal of Orthopedic and Sports Physical Therapy in 2015. So let's look at the past studies for the Thessaly Test. Look at the variation. Yet with one exception, the specificity remains high. So what about this study? What's unique and different? This study involved a large number of patients, 593. They were 18 years or older and were referred to an orthopedist for arthroscopic evaluation of a possible meniscus tear, which means that they were in essence pre-screened, leading to a higher prevalence of meniscus tears in this group compared to general practice. There was a comparison to the McMurray test, and arthroscopy was used as the gold standard. Here we can see the patient positioning for the Thessaly test. The patient stands on the involved leg, bends to either 5 or 20 degrees based on the variation being used, and rotates on that knee. Again, pain may be the only required response, or clunking, clicking, or popping may be used. So what is a positive test finding in this study? Well, for the Thessaly test, the patient had to have discomfort or pain at the medial or lateral joint line, or locking, catching, or a feeling of giving way. And for the McMurray test, there had to be pain and or a clicking sensation. So here are some results. 83% of patients had a meniscus tear. 25% had a meniscus tear alone. 58% had multiple pathologies with a meniscus tear, and 14% had other pathologies without a meniscus tear. And 70% had a medial meniscus tear, and only 15% had a lateral meniscus tear. 16% had both medial and lateral meniscus tears. So before we look at all the stats, let's quickly review two other important ways of stating the value of a test: predictive values and likelihood ratios. Simply put, predictive values take into account the prevalence of the disorder in the study population, whereas sensitivity and specificity do not. In other words, it is reflective of the performance of the test relative to how many patients had a meniscus tear in the study population. We'll look at that in a moment. Next, likelihood ratios. These are sometimes divided into positive and negative, reflective of the number generated and how it relates to helping to rule in or rule out. Its value is in predicting the likelihood your patient has a disorder based on the findings of the study. Here are the specifics, but really the number and its effect on decision-making is most important. Here we can see that a likelihood ratio of 10 makes a large difference in the probability the person has the disorder. But we can see that if the likelihood ratio is between 2 to 5, that change is very small. Now altogether, the Thessaly test had a sensitivity of 64%, a specificity of 53%, a positive predictive value of 87%, and a negative predictive value of 23%, and a positive and negative likelihood ratio of 1.37 and 0.68 respectively. The McMurray's test performed pretty similarly when looking at predictive values and likelihood ratios. The overall accuracy is the proportion of patients who are correctly identified by the index test results. In this study, the overall accuracy was 62% for the Thessaly test alone and 54% when combined with a positive McMurray's test. Not great. Let's put it together for your patients. Using something called a nomogram, we can use the likelihood ratio and the prevalence of the disorder to determine a post-test probability that your patient has a meniscus tear. In the study, the prevalence was high, 83%. The line starts there at the pre-test probability and passes through the likelihood ratio of about 1.3 to end up at around 80% post-test probability. No big improvement. But the confounding factor here is that these patients were pre-selected because there was already a suspicion of a meniscus tear, and that suspicion was probably based on a traumatic history, signs and symptoms of a meniscus tear, and positive meniscus test findings. Let's say that the prevalence was lower, say 25%, given you don't see a lot of meniscus tears in your practice, and the signs and symptoms aren't classic for a meniscus tear. We can see that again the improvement in probability is minor, taken only from 25% to 30%. Makes sense when you see that the likelihood ratios that are below 2 are not very valuable. So given it's difficult to trust the results of all studies to represent reliable stats upon which to test your patient, what can you do in your practice? Well, the answer is to be a clinician scientist and generate evidence specific to your practice. Sounds hard or maybe impossible. Not so. If you can enter or have someone else enter into a spreadsheet, such as Excel, and you know some basics of operation, in a couple of years or sooner in a sports practice, you'll have some reliable data. Here's how to set this up. The patient's name isn't necessary, but perhaps a chart number can substitute as a sorting indicator. Next, every time a patient presents with knee pain, you enter them into the spreadsheet. Across columns, you enter the variables mentioned at the beginning of this presentation. Here they are in a sample, limited version. After accruing perhaps 100 or more patients, it would be easy to sort first based on verified meniscus tears. You could sort by arthroscopy confirmed or MRI confirmed. Then you can cut and paste these into a new sheet and sort by positive test results. It will become fairly clear if there is a winner or cluster of winners that are the most reliable. So here is an example of that with 25 patients. Using ones for positives or yes, and zeros for negatives or no, you can sort by column. In this hypothetical example of 25, I then sorted by those with a known meniscus tear based on arthroscopy. Here we see some significant things. All had trauma, classic signs and symptoms, and all had a positive Thessaly test, but not all had a positive McMurray's test. Again, this is hypothetical, but demonstrates how with little investment in time, you could judge the value of the tests you use in your practice based on how you perform them in your practice. This doesn't need to be limited to the knee or to the tests used in this hypothetical example. Try it out and have fun. It'll enlighten your practice and improve your practice. So to summarize, the results from this current study of the value of the Thessaly test indicates that prior studies may have overestimated the ability of the test to add value to ruling in or ruling out a meniscus tear. And although disappointing, it reflects most orthopedic testing values when single tests are studied. In many cases, it is the accumulative effect of multiple positive tests that have some value. Single test positives or negatives often add little to the probability that a patient has or does not have a specific disorder.